Good morning, good afternoon, and welcome to our webinar, Universal Access to Care. How can we overcome barriers in the patient journeys? And we all know access to care is absolutely essential for patients, for citizens, for families. They need to have access to the diagnostics, to the treatments, but also, of course, to health promotion and prevention. But very often, this is not a given because there are gaps in coverage, like, for example, some specific population groups, migrants, asylum seekers, undocumented people, they may not have any coverage. Or the particular diagnostic or care you are searching is not part of your benefits package. So also very difficult. How can you get this? Or the co-payment is so high that you cannot afford it. But even if coverage is a given, even if there's you as a person coverage, the service is covered, and the co-payment is not too high, there are very often barriers. And just think about, how difficult it can be to get an appointment with a specialist doctor. So this may be actually another barrier which we need to overcome. So barriers are everywhere, gaps are everywhere. And we know a lot about the problems, and that is why we have asked all our speakers to really focus on the solution and only talk a little bit about the problems behind this. For us, this is a very, very special webinar. And I have to say, as Observatory, we are really honored to be the official partner for the third day of the European Public Health Week, which is an initiative by our long-standing friends at the European Public Health Alliance. And just to mention this, as you probably know, in November, there will be the EPHA conference in Dublin, and you can meet the observatory there because we are going there. We will have a book stand and we will have a couple of activities. So think about going to the Dublin conference. I'm also very pleased to say that we have two speakers today from EPHA sections. EPHA is organized in many, many sections, and we have speakers from two sections here, Anna O'Donnell and Bernadette Kumar. I will introduce them in a moment. It's Wednesday today, and the European Public Health Week has already started on Monday, and they have already covered very important themes. So yesterday it was about diversity in health, and on Monday, mental health was the topic, and those webinars, those events have been organized by our partners, WHO Europe and the European Commission. But now it's our turn to kick off the theme of access to care. And because it's a very special webinar for us, it's slightly different from our usual series. First of all, we have more time allotted to this webinar. So we have 90 minutes today, which gives us the opportunity to have a little bit more insight into the topic and to look at it from different angles, but also which provides us a bit of an opportunity to have more engagement of you, the audience. And as I said, we have more speakers, and I'm very happy to introduce Bernadette Kumar from the EPHA section on migrant and ethnic minority health. She's actually leading the unit for migration health in the Norwegian Institute of Public Health. We've also here Anna O'Donnell from the EPHA section on digital health. She's Associate Professor of Public Health at the Faculty of Medicine of the University Vita Salute San Raffaele in Milan. And we have Professor Luigi Siciliani from the University of York. Some of you know Luigi. He's been several times on our webinars, and we work very closely on a lot of issues, and access and waiting lists is certainly one of those issues. I'm also very happy to introduce Miguel Arriaga. He is from the Division of Literacy, Health and Wellbeing in the Directorate General for Health Portugal. And also Rosa Castro, who is also Brussels-based from the European Public Health Alliance. Rosa will have a very special role today because at the end of the presentations, she will have some reflections from the point of view of patients and citizens. And last but not least, I would like to announce the participation of our colleagues. My colleague Ewald van Ginneken, who is coordinating the Berlin hub of the observatory, will be today our spotlight speaker. He will introduce the conceptual framework of the topic. We have Juliana Winkelmann with us, and also John Silas, who is actually based in Barcelona. So that was a quite long introduction. Just a couple of mentions on the housekeeping. Please use the chat box for your comments, your ideas, your questions. We will feed your input to the speakers. We will have 2 moments in the agenda where we will turn to the speakers and ask them for their views on your comments. And we are recording this session, and in a couple of days, slightly edited version of this webinar will be on our YouTube channel. So that's about it. And now I'd like to ask Erika to start the participant poll.
Hello, everyone, and welcome. Yes, if we could put the poll up. So just a quick question for all of you to see where we are. Just wanted to know what the biggest problem with access to healthcare is in your country. You can have multiple choices here, but it'd be better if you just picked one. So is it around population coverage? Is it around service coverage? Is it around financial coverage? Are the geographical barriers the main issue? Organizational barriers? Or is there an issue around health literacy and care denial? So just to get a feel for where we are as an audience. Thank you very much.
Thank you so much, Erika. Very interesting. And I think that the questions or the answers you can choose are already kind of directing us towards the conceptual framework of today, which will be presented by Ewout van Ginneken. Ewout, please switch on your camera. The floor is all yours.
Thank you, Matthias. I will focus now on what are the main access barriers, introduce the framework that we're using today, also to analyze the situation in Europe, but also talk a little bit about the gaps in data availability, which I think is a huge challenge that we need to solve, and I think we'll talk about more today. So what are the main barriers in the patient's journey to access healthcare? Well, you already had to fill out a poll consisting of these elements, but let's take it from the start. We have a person with health need. Then there are a couple of barriers they need to overcome before they can realize access. The first 3 all relate to coverage: population coverage, service coverage, cost coverage. Population coverage: does a person have insurance or not? Service coverage: are all the benefits included in the benefit package? A larger problem than you may think. Cost coverage: what kind of costs are covered? Is there a great deal of cost sharing that could also hamper access? So even if you have all these covered and you're good to go, then there are barriers in terms of geographics. Maybe a provider is too far away, or maybe you do not have transport to get there. There are organizational barriers. Are there waiting lists? Maybe problems with workforce, maybe even physical barriers in an organization before you can enter. And then even if you make it into the doctor's office, there can be problems with care denial because of perhaps discrimination or one's own inability to formulate a care request. So if you miss out on any of these barriers, you will have an unmet need. So let's now talk a little bit more about what we know about some of these and also the data. And although in Western Europe especially, we think that we are well covered in terms of insurance, but it's probably not as high as you think. And you can see that in the figure to the right here. You see that in Western Europe, it's better. But if you're moving to the East, you have insurance, people without insurance up to 10% and more. And the situation doesn't get any better if you move further to the East. So that's still a huge problem. And so who are these people? It's often Roma individuals, homeless people, who are the ones without insurance coverage. But also an increasing problem that is not always on our radar is people who are not paying their health insurance premiums for a variety of reasons. And that can also lead to, in some countries, to loss of coverage or loss of certain benefits. I need to caveat here that this data is often difficult to interpret, and there are different surveys, methodologies, and that can also lead to differences and overestimations and underestimations. So one of the population groups that that deserve attention are the Ukrainian displaced persons who now receive coverage under the Temporary Protection Directive. And the good news is here that they are quite well covered. So more than the directive requires in most cases in Europe. The directive mostly requires medical care that includes at least emergency care and essential treatment of illness. But many countries provide full access to the health system, sometimes even with some extra help in terms of financing. Then if you look at the benefits, we did a paper a couple of years ago on gaps in coverage and access in European Union. And yes, health systems in Europe typically cover a wide range of services, but some countries do limit the scope for certain population groups that we will hear, I think, later by one of our speakers, including asylum seekers, refugees, undocumented migrants, who also, if they register with authorities, may, have the fear that they face deportation, but also citizens from other countries may not always have access, people visiting. And there is a wide variation between countries, and the most included or excluded services include optical treatments, dental care, which we'll hear about as well later, especially for adults, physiotherapy and assistive devices. But even if it's included in the benefit basket, there may be certain conditions attached, like age or medical indication, and those can differ hugely, even between neighboring countries. Think of, for example, of a hip replacement. In some countries, they are performed with people who are well into their 80s or 90s years old. Also, the coverage of pharmaceutical products should be mentioned here, and that can particularly affect cancer patients and patients with rare diseases. But even if you have something, a certain illness or groups covered in your benefit basket, the devil is still in the detail. We did a study, and you see one of the papers that was published out of this to the right here, which was exploring dental care, where we had patient vignettes on stroke, depression, and dental care and palliative care, and they revealed important gaps in coverage, even where formal coverage for such services exist. So meaning that certain specific services were not available. Take, for example, the stroke example. Many countries do not provide rehabilitation care, which is actually, needed to recover from stroke. And, all recommended international guidelines would agree on that. But also low thrombolysis and thrombectomy rates, which then suggest that some countries do not receive, people in those countries do not receive the recommended care. Another example are reproductive services, which will cover a wide variety of services between countries. We're actually doing a study on that currently and hope to publish it later this year. So cost sharing is, of course, a huge issue, and in some cases can lead to catastrophic spending. Those countries where spending is higher out of pocket, you also see that the households have higher catastrophic spending, and John, I think, will talk about that later. We did a paper on this issue as well, and we really need to understand better what are the root causes for this OOP spending. Is it just cost sharing, or are people completely paying services out of pocket because they're not covered by their system? So indeed, all the discussion that we're having must consider the service access dimension. And we need to realize that even if you have full coverage, it does not automatically translate into access. And I think we saw that during the pandemic and the large backlogs that have arisen as a result, and now also the workforce shortages that were also exacerbated by the COVID-19 pandemic. Still, if you look at the international data that we have available, we see that being too expensive and waiting lists are the most common and main reasons for unmet medical care needs in 21. And distance plays a much smaller role, but we need to understand better the role of geography in organizational issues. We do have specific studies, but on the whole, we do not know in a comparative way between countries nationally what happens. And even if you then make it into the doctor's office, we need to understand what is the mechanism why certain people do not get the care they need. And we need to understand that better and work on that more. So as a result, also unmet needs have remained at a very high level in 21 and 22. Just look at the left side here. Almost 1 in 5 respondents has an unmet healthcare need in 22. And it's mostly concentrated on hospital, specialist care, dental care, and mental care. Although for hospital care, it's going back a little, but in other areas, it was increasing during the pandemic, like dental, like mental, but also GP care a little bit. Striking is actually the unmet needs for mental health care by age. of the people reporting an unmet need, 62% in the age category 18 to 24, sorry, now 49% in 22, are reporting an unmet need, which is huge. Also, all among women, 1 in 4 with an unmet need report unmet mental health care needs. So this is an issue that we need to urgently address. People are not accessing health services that they need for mental health. This brings me to the broader issue of the available indicators who fail to eliminate the underlying reasons for those access gaps. And if we don't really know the underlying reasons, it's hard to develop concrete policies to target them. We don't have the granular, systematic, and comparable information, for example, on the benefit baskets and what they actually cover. Then we have European services who include certain people like under 16 or in communal housing and institutions, meaning that these are missed. And so it may be an underestimation in those data. And then European surveys do not collect data on health conditions so that we could link to certain patient groups or social and legal status, and whether discrimination or care denial plays a role, which could all help us identify these vulnerable groups. And then with regard to financial indicators, we do collect information on OOP, but we cannot always disaggregate between direct payments, meaning it's not covered in the system, or it's because of cost sharing is too high. This is important information to know if you want to act on it. And similarly, the European surveys do not provide insight into whether unmet needs or financial reason is resulting from lacking coverage, statutory coverage. Is it service coverage the problem, or is it cost coverage? So there's still room to improve quite a lot. So just to conclude, the countries have gaps in coverage and access, and they are pointing mostly to well-known groups of vulnerable people. I think in most cases we know who they are. Access and health outcomes are severely affected by the pandemic, which is something that should really deserves our attention. And although we have a long way in terms of data collection, we still need to improve data collection on a national and European level. And that will be a prerequisite to have better, more targeted policies and increase access for people in Europe. Thank you.
Thank you so much, Ewout. Thank you so much for this excellent overview. And I think it has clearly underlined the importance, to discuss access to care, actually, and not taking for granted that coverage is all actually there and that there are no barriers on the very different, on the very contrary. And as you said, the devil sometimes is in the detail. I find quite shocking the figures on unmet needs for healthcare, and as you have said, mental health issues are not really treated well, and COVID-19 and post-COVID-19, have caused so much distress, and that's really an important issue. But also, it's a bit sad to see that this is really research, that there are no readily available indicators where we can assess the unmet needs, where we can assess access very, very easily. Thank you so much, Ewout. And that's the moment where I would like to ask Erika to present the results of the poll, now that we have heard the backstory to all the questions. Erika.
Hello there. Thank you very much. Well, interestingly, it was the organizational barriers were the ones that people highlighted. It'll be interesting to see in the chat where those organizational barriers are, whether it's waiting times, whether it's something else. But also, sorry?
It does reflect actually what Ewout was saying, that you need to look at all the coverage issues and all the barriers, because they are almost everywhere.
Absolutely, absolutely. There was only a couple of people who said that none of the above were an issue in their country. I'd like to think that was because coverage, and there are no barriers, and the coverage is great in their country, but it might be that there's something that we've missed from this list. So please do put it in the chat. Thank you very much. Back to you.
Thank you, Erika. And I think that we will deal with this poll later on. And now it's my great pleasure actually to give the floor to Bernadette, our first speaker on population coverage. Bernadette, the floor is all yours.
Good morning, everybody. And with that, I'd like to take off, and it's going to be a whirlwind tour in 5 minutes, talking about overcoming barriers in the patient's journey, and present to you the case of migrants and ethnic minority groups. Today, we know that the world is facing a lot of challenges, and a lot of these challenges are global, and we need local solutions. So next slide, please. So that's the world today, and we won't dwell on that. Next slide, please. And we also know that due to the pandemic and a lot of the other challenges, UHC, or the universal health coverage, has for the time being been derailed in a lot of areas of the world, and notwithstanding Europe. And I'm going to talk to you about the coverage mechanism, especially the Ask 2, which is leave no one behind. Next slide, please. Migrant health. I'm not going to go into all the arguments of why we should bother about migrants and ethnic minorities groups and refugees. But I think the most compelling argument of all is the humanitarian argument that we cannot forget. Next slide, please. We also have increasingly a lot of data that is available about migrant health, but a lot of this data is incomplete and not available as routine data, and definitely not when it comes to coverage. Next slide, please. However, the MIPEX, or the Migration Integration Policy Index, has tried to review access to healthcare in Europe. And as you can see that the countries in Europe are divided into four quadrants, with good access and good quality, good access, poor quality, poor access and poor quality, poor access and good quality. And you can see that the migrant groups in particular, a lot of them are in the poor access and poor quality group, because many of them fall out of the entitlements and rights that other citizens in countries and host populations have. Next slide, please. We also see, and I think you can just continue because this is an animated slide, that the EU countries, according to tackling health inequalities, and the colors here tell you that we have a long way to go. And some countries, particularly in the red, they need to do some. The other countries need to do more, better, and the last group needs to do more. Can you take the next slide, please? Do some, do more, and do better. Thank you. The framework for understanding access and use of health services, particularly in the case of migrants and ethnic minority groups, there are 5 A's: the approachability, acceptability, availability, affordability, and appropriateness. And if we look at the SDG 3.8, we can see that the access is really not only about financial barriers, and I'm glad that other colleagues will talk about it, but all these issues, in particular for migrant and refugee groups. Next. So when we talk about migrants' access to healthcare, and this is very related to their coverage, you have formal factors like legal rights, but also you have a lot of informal factors: information accessibility, family responsibility, job security, care providers who don't have sufficient knowledge, delays in diagnosis and treatment, navigating the health system, long waiting times, the attitudes of care providers which are discriminatory, and dissatisfaction with healthcare providers. And all of this leads to increased morbidity and mortality. Next slide, please. So what are the solutions? And this is the main point. Of course, rights and entitlements, if we have people that fall out of this particular area, then their access is stopped. And we have seen both with the temporary directive of the Ukrainians, as well as what happened in COVID with countries like Portugal, for example, leading and allowing all migrant groups, including undocumented migrants, to access healthcare. We also have to enable patient navigation, user involvement, and asking how these services, once they get into the services, can be made more accessible to the migrants. We have to promote health literacy. The use of translators is extremely important, and we must build the competence of the health workforce. We also lack a lot of not only the data that Yvonne mentioned, but also we lack interventions and good practices that can actually document these facilitators and enabling factors. Next slide, please. And my last slide is basically a call for action, because, and the most important thing about this call for action is inclusion. Inclusion of migrant voices, embracing diversity, zero tolerance for discrimination, xenophobia, and racism, building up the competencies of services, reducing the inequities. And one way of reducing the inequities is actually increasing coverage for these groups. And this cannot be done if there's no accountability, if we don't hold. It's not only the lack of policies, but the lack of implementation of policies that do exist. And for that, we need the leadership, and we also need partnership. Thank you very much.
Thank you so much, Bernadette, for this excellent presentation. And I think it was very, very clear. It's not a minor problem or a side problem, but with all the migrational activities we see coming from the wars in Syria and Ukraine, coming from Africa, but also labor migration, this is really very important. And you were mentioning the SDGs, the SDG 3, actually something which all member states have agreed upon, and they should be covered. They should look after migrants, and still we don't do this. But thank you so much also for filling us in on some of the solutions. And as we can see again, it's not a single silver bullet, but there are plenty of activities which need to be taken into account when you want to resolve the coverage problem of certain population groups. That's great. Thank you so much, Bernadette. And that's the moment where I would like to invite our second speaker, my colleague, Juliane Winkelmann. Juliane, the floor is all yours.
Thanks for inviting me. I'm covering and looking at the service coverage part of the whole coverage topic. So we mentioned, Ewald mentioned already that dental care is one of the main areas after pharmaceuticals and medicines, which is often not covered or not fully covered in terms of when it comes to services. In most countries, there's a large share of out-of-pocket spending for dental care, and unmet needs for dental care are actually quite high. Also, even before the pandemic, it was one of the medical areas where out-of-pocket payments and unmet needs were the highest across the medical care areas. So in one cross-country comparison, we have looked at the coverage across the countries, and we saw that there's large diversity across the European countries when it comes not only to the benefit basket, but also the statutory benefit basket, but also to cost sharing and population coverage. So we can see that in some countries like Spain or Portugal, coverage is quite limited. When it comes to the benefit basket, the service coverage in Spain, for example, there are very few benefits which are covered, like tooth extraction or emergency care, the same as in Norway or Italy. While in other countries, like in the Czech Republic, Austria, Germany, the benefit basket is actually quite comprehensive, even covering dental cleaning, restorative care, prosthesis, etc. So in terms of really services coverage, dental care is actually a nice example where we can see a large diversity in countries. And we were asked to talk about the solutions that countries are taking to approach, to counteract the service coverage gaps. And we can see actually that a number of countries in Europe have recognized this access problem, and have introduced reforms. Like Ireland has introduced in 2019 the new national oral health policy, in particular to reduce coverage gaps for children, elderly, and vulnerable people, and introduced actually 8 oral health care packages for children, like examination, preventive advice, etc., which is replacing the current model that provides dental care for children only in school settings. And I think the most comprehensive reform in the area of dental care to introduce a more comprehensive coverage is currently taking place in France with a 100% santé scheme, and they really try to implement a full coverage of a range of dental services, include increasing the coverage of prosthesis and to reduce cost sharing. And they have a focus on preventive and less invasive treatments. So this is very positive. And last but not least, I would like to mention Belgium, which has recently also increased the coverage for dental checkups, which is now fully reimbursed for all adults. So as Ewald mentioned before, dental care is the service coverage for dental care is particularly limited in most countries for adults. In many countries, children are quite well covered, but when it comes to adults and sometimes also elderly, service coverage is very much reduced. So this is just to give you an overview of what is happening, and I think more countries are on their way to extend with small steps their service benefit basket, but also cost sharing, reduce cost sharing for dental care. So there are some countries recognize this importance of dental care for better access to care. Thank you very much.
Thank you, Juliana, for this excellent, very concise overview. And I think it's a very stark and telling contrast to the map that Ewald was showing, because Ewald showed a map with population coverage, and to the west, everything was dark blue, close to 100%. And now we see the differentiation when you show the service coverage for dental care. It's not all blue, it's quite checkered picture. And many countries which seem to be very good in population coverage need to work on the service coverage, in particular, of course, your examples on oral care, but I can figure that optical care and other services are also very important. Thanks a lot, Juliana. And now that we have covered population coverage, service coverage, we are coming to the financial coverage issue. And it's my great pleasure to ask my colleague, John, who is based in Barcelona, to show his fancy slides. John, the floor is all yours.
So I'm going to talk about financial coverage. Very briefly. So I think this is something that we all know. All countries in Europe rely to some extent on out-of-pocket payments to pay for healthcare. So out-of-pocket payments being co-payments, being direct payments for services that aren't covered or which people buy from the private sector. Informal payments as well are out-of-pocket payments. And this figure shows the extent to which countries in Europe rely on out-of-pocket payments to pay for healthcare. And so it's a big, lot of variation all the way from Monaco, about 7%, to Armenia and Turkmenistan, nearly 80% of spending coming, being paid by households at the point of use. The animation begins. And so for some households, these out-of-pocket payments cause financial hardship. Now, Ewald showed this slide, or a version of this slide, in his presentation, so I won't talk much about it. But what this shows on the horizontal axis, this is the share of health spending that's coming from out-of-pocket payments. So the same data that I showed on the previous slide. And on the vertical axis, this is households with catastrophic health spending. And so in Europe, we measure catastrophic health spending based on whether a household spends more than 40% of their capacity to pay on healthcare out of pocket. And their capacity to pay is defined based on their budget after accounting for the cost of meeting basic food, housing, and utilities needs. And what you see here is not surprising. The countries that rely more heavily on out-of-pocket payments, the countries further to the right, generally speaking, they have higher catastrophic spending. They have more financial hardship. But what I want to draw your attention to is this. So obviously there's a lot of variation. So you can have two countries or many countries here. In this case, we have the UK, Slovakia, Poland, I think that's Romania at the top, all which rely more or less to the same extent on out-of-pocket payments to pay for healthcare, but they have very different risks of financial hardship. So varying from very low in the UK, around 2% or so, to around 13% in Romania. And so the question is there anything we can do about this? So to illustrate, we've done a modeling exercise. So to try and show that how your risk of financial hardship varies not because of who you are, but because of the country that you live in and the coverage policies that are in place. We've done this modeling exercise using data for European countries to predict how a particular type of household what their risk of financial hardship will be under different types of coverage policies. And we focus on coverage policies for medicines because medicines are the main driver of health spending. So in this case, we're going to look at Lisa. This is Lisa. She's 72. She lives in a big city. She's not working. She has a very small pension. She has a lot of chronic conditions, but she spends about the same amount out of pocket on medicine as the median adult in her country. And so what we want to see is, how does her risk of financial hardship vary depending on the coverage policies that are in place, the co-payment policies really in this case for medicines. And so to see, we're going to watch Lisa. So this is Lisa. If Lisa lived in Bulgaria, we would estimate based on historical data that she would have about a 20% risk of being a catastrophic spender. And this is because in Bulgaria, there's very limited mechanisms to protect people from out-of-pocket payments. But here we go. If Lisa moved to Germany, sorry, let's move that back. if she moves to Germany, where there are low fixed co-payments for medicine, so between 5 and 10 euros, so it varies, but doesn't vary very much. And there's income-related caps, so she can't exceed, I think it's around 2% of her income. Lisa's risk of financial hardship, whoops, wrong direction. There we go. Now she's flying to Germany. Her risk would fall to 9.7%. Now, if Lisa lived in the Czech Republic, in Czechia, where there's not only low fixed co-payments and caps, but there are also exemptions for vulnerable groups, so exemptions from co-payments, then in Czechia, Lisa's risk falls to just 4.4%. So the exact same person in different contexts. Why is her risk of financial hardship so different? And the answer, of course, is the coverage policies. It's the co-payments used for medicines. So with that, I will stop. Thank you very much.
John, thanks a lot. And it's a great example. I think everybody knows Lisa, and seeing, that it can be so easy to be financially protected, actually, and financially covered. Just moving to another country is quite encouraging, because it tells you that change is actually possible. And Czechia is providing probably a very, very good example on this one. But also, again, if we look at the three elements, the three dimensions of coverage, you out of a sudden realize there are so many cracks in the system, and it's almost hard to avoid that you fall into one of those cracks. So I think they multiply and they make life very, very hard for the people. Okay, so that's the first block on the coverage. Thank you so much, John. And please keep your camera on, and Bernadette and Juliana, please join as well. We have a short couple of minutes time to see whether something has come through the chat box with regards to your presentations. Erica, are there any questions or comments which we can quickly address?
Yes, it's been a very busy chat box. Please do keep your comments, questions coming in. There's a question for Bernadette, which is about the specifics. What should we do? What should we do at a country level of specific policy? Just pick one thing that we should all be changing, and whether or not there are needs of different needs of migrants need to be met in different ways, depending on whether they're economic migrants, refugees, etc. For dental care, it's more of an intersectional thing. What about coverage for uninsured people? So how do we extend dental coverage to people without insurance? Question for John: how can we improve financial coverage and contain costs? So is that how can we achieve that? And one for I think this one's probably for Ewout, and it's about intersectoral working and coverage, top tips. So how can we include things like health education and prevention and coverage for all of these things all together? Okay.
Great question. Thank you so much, Erica. And shall we start in reverse order? John, you go first.
I'd be delighted to. So this is a great question. I think this is something, so how to improve financial coverage and contain costs. So I think this is something that many countries are facing, especially now post-COVID. There's a lot of pressure, obviously, upwards pressure on spending. And of course, there's a lot of fiscal constraints, especially with high inflation. I think the key is to focus on that second slide that I showed, the scatter plot, where you can see that actually countries that rely very similarly on out-of-pocket spending, that have the same percentage of their health spending coming from out-of-pocket spending, they have very different risks, right? So you don't necessarily, it's much, if you're a country that is relying 60, 70% on out-of-pocket payments, this is a big challenge. But if you're a country that is maybe 20%, 30%, it's really about the policies that are in place, and that the policies, the effect that they have is on the distribution of health spending. So of course, not all households are going to have the same risk of financial hardship when they face out-of-pocket payments. So if you have a very poor household, these are poor households that cannot really afford to spend anything. It makes much more sense to have them exempt and make this exemption process administratively very straightforward. But if you are wealthier, then there's caps, there's other ways. So I guess the key message there is that countries can afford to do this. It's really about distributional issues. It's not necessarily about spending more, it's about spending differently.
Thank you so much, John. Juliana.
So yes, the question was about coverage of dental care for uninsured population groups, I think this issue is not only concerning, of course, dental care, but also other medical care areas where there's a huge access problem for those without insurance. And I think in most countries, they can access via emergency services or practices that are providing services for uninsured. But of course, I think in dental care, it's even more a problem because dental problems are not such a big health threat to people. So they really delay going to see a dentist, to see a specialist, those who have no insurance. So I think it needs some general response to those who are uninsured to provide at least some basic services, not only for dental care, but also other.
Thanks a lot, Juliana. Bernadette.
Yes, I'm going to try and answer this question cover several things. First important point, migrant groups are very heterogeneous. Second thing, European member states and countries in Europe do not have the same financial coverage. It's tax-based sometimes, and sometimes it's also insurance-based. So there is a lot of differences. So we cannot have one shoe fits all in terms of the country level. So the country has to look at what is it that in that particular country will make the most difference. But the outcome for all member states should be the same. And that is inclusion of migrant groups into the policies that exist, not making separate policies for them, and to ensure that nobody falls out of the cracks. And then we also have to know how can we include the migrants, and the how we don't know. We know the what and we understand why we should do it, but the how, which it requires interventions and practices, is still missing in our database. Thank you.
Thank you so much, Bernadette. In any case, the main message is inclusion is necessary, and not just having separate laws or regulations for those population groups. Ewout, a quick one. We are running a little bit behind time.
This is a really good question. I interpret it like, what is the role also here of health education, health promotion, prevention in all this? And it's an important one, which I didn't highlight. Of course, you want a need, if you can prevent it from arising, you relieve the system and you improve access for others. So it's definitely a lever that we need to carefully look at, and also because there are huge differences in utilization between countries, so there's lots to gain there, and it's actually an important point to account as well. Thank you.
Ewout, thank you so much for this very concise response, and I think we can move on now to the second block of our webinar. We move on to spotlight on organizational barriers, which would be Luigi. Luigi, please.
Good morning, everyone. Thanks for having me. Let me just take a second to share my screen. I have only one slide, so that should be simple. So I was asked to focus on solutions in relation to waiting times as barriers to access. So I will not try to convince you that there is a problem there. I think we know that there are like backlogs of different size across countries, but they're quite across Europe. So if you're thinking about how to address these backlogs, what can we do about it, and what have countries been doing about these backlogs? So that's what I want to cover in my 5 minutes. So I think if you have this backlog, the starting point has to be to increase the volume and the supply. So that's if you agree with that starting point, then maybe you think like what is the implementation of that? And a few countries have tried to contract extra hours, extra sessions for existing providers. And that sounds all good, but immediately you face some hurdles and some problems which all relate about the health workforce. So you can ask the health workforce to work harder, but we know that they have just gone through a very difficult period, so they are exhausted. So I think part of the solution there has to be about policies that help the workforce to have a better working conditions, for example. And mostly, you could argue that you would want to expand the health workforce, but I think the way we are at the moment, this is more about the retention policies of current workers. So we hear a lot of stories of people who are leaving the profession. So really there is the issue of the backlog, in my view, is quite closely connected to health workforce issues. And although you may think that these retention policies are kind of disconnected, they are actually quite closely connected. The second point I want to make in relation to expanding the supply is activity-based financing. Again, across a range of countries, we know that activity-based financing has quite a lot of limitations. But given the situations where we are at the moment with quite a lot of backlogs, I think actually we could stick to activity-based financing before we move to some other financing models, because that has a financial incentive that is aligned with the expansion of the supply. So if there are some pockets of capacity in the health system, then you can use activity-based financing to ensure that the providers who make that extra effort, they are rewarded for cost, and hopefully maybe that those additional resources are also redistributed in part to the health workforce, which again is key to act on that additional supply. Some countries have also contracting with private providers for the benefit of publicly funded patients. So you can try to use, and countries have been trying to use that existing capacity to expand supply. The catch there is that these private providers often recruit the same doctors and nurses working in the public system, so there is potentially a conflict of interest. So however you look at this expansion of supply, for every single of these, you keep going back to these health workforce issues. Okay, so that's the first element, increasing supply. The second element that I want to cover is maximum waiting time guarantees. What we know from 20 years of looking at health policies on waiting times is that if you only focus on increasing supply, that's no guarantee that the waiting times go down. But if you combine it with maximum waiting time guarantees, that is more likely to happen. Now, there are many design issues around how the maximum waiting time guarantee or a maximum waiting time. Often this can take many different forms. The common successful way, in my view, is one that has a generic, very simple maximum waiting time guarantee, say no patients should wait more than 4 months. And then you have some areas that are prioritized. So we want to have shorter waiting times for cancer, for some cardiovascular conditions. But there is an element there that you cannot make it too complicated. So potentially you could have a maximum waiting time which is different for every single treatment, but that's too complicated. So again, I think that the successful policies relate to keeping it simple, having one generic maximum waiting time, and then some shorter ones for some priority areas. Now, that brings me to the third point, which is demand management. If you're thinking about bringing down waiting times, again, if you want to look at this big problem that we have at the moment in a more positive way, this could be an opportunity to eliminate perhaps some inefficiencies that we have in the system. We have lots of parallel discussions in health policy about unnecessary care or low value care. Well, given that we have a backlog, this is the opportunity to try to do that. If we manage to eliminate the low value care or the unnecessary care, then that will help also with the backlog. Now, that sounds easier than done. The problem there is that if you're reducing access to care and you're trying to reduce access to unnecessary care, you may also reduce one to the necessary care. So it's not so easy to identify the necessary versus the non-necessary care. In terms of demand management, also, it's not only about trying to reduce demand, it also manage demand. So I think that's where I want to discuss briefly waiting time prioritization. There is quite a lot of prioritization already in the system. There is prioritizations across different treatments. We know that waiting times for coronary bypass and angioplasty are much shorter than for a hip replacement. That's prioritization across treatments, but you can also have within treatments. So if you have different patients, some are in pain or not so mobile, then you can redistribute the waiting times from those who can afford to wait to those that have a higher benefit that they have a higher cost of waiting. There are also some policy discussions around coordinations between primary and secondary care. So again, there could be some solutions there to make sure that primary care doctors, they can treat some patients in their setting rather than pushing it to the secondary care. And when they instead they refer them to the secondary care, then they have like also a prioritization system so that they can flag easily the specialists, the urgent versus the less urgent ones. And there are some policy initiatives that have tried to push that. There is some studies suggesting that sometimes specialists receive some referrals that look very urgent while they're not so urgent. And the last point I want to mention just briefly is in relation to diagnostic tests. Again, if you look across countries, some countries have tried to boost supply on diagnostic tests because that can be the bottleneck. So perhaps you have capacity to treat the patients, but if you haven't done the test to make sure that you know what treatment is the right one for the patient, then you are creating some inefficiency in the health system. And I'll stop there. Thank you very much.
Thank you so much, Luigi, and thank you so much for presenting this toolbox of strategy to overcome actually these backlogs and waiting times, supply guarantees, demand management. There's a lot in it, and of course, again, the devil is in the detail. But apparently, there are ways to do it, and some countries are fixing this, and that is really great news. Thanks a lot, and I would like to ask Miguel. Miguel.
Thank you so much. I brought this picture, and this will be the only pictures that I will show, the only slide that I have to represent you the challenges that we have when we are facing and when we are working with health literacy and the way is to promote and to help people, the citizens, the patients to navigate within the system. I would say that is a big challenge, and I will try to explain to you afterwards some of the ideas that we have also related with this picture. As you know, health literacy has been one of the areas that has been more developed in the past few years, because it's an easy way to promote and to help people to navigate, to have healthy lifestyles, and even to promote the adherence to treatments. But at the same time, it's a big challenge, because as you all know, when you talk about health literacy, we need to talk about the accessibility, we need to talk about all the interventions, we need to talk about the comprehension, but we need to talk about a specific point that we are working on a lot now, which is for people to use the information that they already can access and that they can understand. So we have big challenges in the previous dimensions of health literacy, and we have a bigger one, which is to use that same information. So what apparently it's an easy way to promote and to help people, in fact, it's also a big challenge. But several countries are working on health literacy in the different fields of health. I would say in health promotion, with a lot of information and with a lot of projects that we have. And I would like to focus especially today about the navigation. I can give you the Portuguese example, and we can talk about the adherence to vaccination within COVID, which was, I believe, for every country, a very good example on the importance of health literacy and the way to engage population for a better and easier approach, and also to how can we adhere to treatments, how can we talk about polymedication. So health literacy has a big role in all of these dimensions, but as I was mentioning, it's not an easy job or an easy way to do it, and that's why I brought this picture. As you can see, this was still a road under construction. I would say, and I usually say, it's a very well designed road with a cross lines here, with a sidewalk, but sometimes what we find is that people don't want to have or for some of the people, they are in fact using the sidewalks that the designers, that the engineers, that the architects promoted, but sometimes people just want to get faster from the point A to the point B. And for that, it's also a big challenge, because we need to help them to navigate. And usually the navigation systems within the health system, it's not organized thinking about the person's need, but it's organized thinking about all the different concepts and all the different strategies and all the different mechanisms and approaches that the system already has. So that's a big challenge and a big step forward that we need to give for the future. And this is one of the challenges that we need to use. And for that, we have, of course, technology. We have e-health as one of the most important steps for the future. For example, the health for first consultations, and as well as we can talk about, for example, the health lines that help us a lot. But at the same time, it's when you talk about all of these fields, and especially when you talk about e-health, we still are need to talk about the more, and I will call it classic approaches on how to help people and how to promote and to give them information related with health. And for us, we know that to talk with health professionals, to have the health professionals' opinion or guidance within all of these systems is still extremely important, because unfortunately, e-health, it's not for everyone. It still causes some dimensions on inequities on health. So we need to think about all these approaches, thinking about the more conservative approach and the new developments that we, of course, need to use. So in fact, this picture wants to represent the challenges that we have for the future. And I would like to mention the importance of co-construction on our approaches, and to talk with people and to have it and to promote something that I believe that is extremely useful and extremely important for us. And I will finish with that. It's to make the correct choice and make the correct navigation the easy choice. And for that, we need to work a lot, not only with the new developments, with EPHA, with artificial intelligence, but also to work a lot with people and with people needs. And I believe that for that, health literacy has a very important role, as well as behavior science. And thank you so much, Matthias, for your time. And I hope that this time you can hear me well, loud and clear. Thank you so much.
Very well, Miguel, and thank you so much. And thank you so much for keeping cool despite all the technical glitches. I think, you know, when you were talking about the health literacy, to some extent, I thought this is really the link to what Luigi was saying about the demand management, and you've widened the perspective. Actually, it's not only, you know, that you need to manage the system itself, but you need to give people the means, you know, to empower them, you know, to do the right directions, the decisions, and also contribute, you know, to the efficiency of the system, and especially to access. Thanks a lot, Miguel, and later on we will ask you to join the panel again. Now it's my great pleasure to ask Anna O'Donnell. She's the second speaker, actually, from a European Public Health Association section, and she will talk about geographical barriers. Anna, the floor is all yours.
Thank you so much, Matthias, and good morning, everyone. It's indeed a great pleasure to represent the digital health section of EPHA during Public Health Week. I believe that we understood very clearly from previous presentations that barriers to universal access to care are a multifactorial and very complex issue. And I do really congratulate the Observatory for having created this framework that had different levels. We heard about population barriers, service, financial, organizational barriers, and with this last presentation, literacy barriers. Now we focus on geographical barriers. And if we think about the patient's journey to care, which is the running title of this workshop, we can make very practical examples on which are the geographical barriers to access care in different contexts. Not easy to get to the service without help, too far away from clients, have to rely on public transportation, nowhere to park, transport not very often, having to rely on caregivers and other people to take you to consultations, or living in a rural area. So geographical barriers to care have been quantified in different geographical contexts and in different settings. What we can say is that there are geographical barriers at different levels. Most likely we have evidence on people living in rural areas, but there is accumulating evidence on geographical barriers to care in urban settings. Geographical barriers are differentiated by type of health systems that we do have in different countries or in different regions. They are distributed in strata of socioeconomic status and in strata of health literacy and health education. So the true objective is how to reach more people and reach people better, overcoming geographical barriers with an overall aim to get care there where people live and work. So we go to the WHO concept of people-centered care in overcoming geographical barriers. And so we, within the digital health section in EPHA, back in the pre-COVID era in 2019, discussed about how digitalization in Europe can support this process, considering digitalization a tool to fulfill public health values and objective in accessing care. So the benefit of digital health is that, beyond others, helps to put people at the center and support their empowerment. And so we created a conceptual framework where we divided all public health domains and the available digital technologies, highlighting which features different digital technologies had to get to the health benefits in this specific discussion that we're having this morning, overcoming geographical barriers. And this brings me to talk about, you see in the box on the slide, tele-services, what we call, there are different definitions, but we can call telehealth. And with COVID, and COVID came, we know that more and more people are overcoming those geographical barriers, is accessing care through online services as a way to overcome physical barriers, as the examples that we heard about at the beginning of the presentations. And we know that the access to care through online services has accelerated, has been exponentially increasing during COVID to take care of COVID health emergencies, but also to overcome geographical barriers to taking care of other diseases other than COVID. And you see here data that shows us that has happened in many countries in Europe and beyond, with great success, but also barriers within this solution to overcome geographical barriers that have to be taken into consideration. So the share of adults in OECD countries that had medical consultation online or by phone between 2020 and 21 increased to 45% as an average value, which is a lot. So this tells us, and other scientific evidence has kind of quantified the status and the current use of telehealth and telemedicine across the World Health Organization in the European region, telling us that these services has increased exponentially, but with some problems and some other barriers that have to be overcome. We have a list of best practices and successful examples across the EU. I'm thinking about Norway, I'm thinking about Scandinavian countries, thinking about some areas in Italy, not throughout the country and not at the national level. So we do have best practices that can be scaled up and adapted to other European settings, but let's say the policy around introducing telehealth in national health systems is a little bit beyond what technologies allows us. So within EPHA, we propose pillars for a successful European strategy for public health digitalization with specific reference to telehealth, which includes, of course, political commitment. And now we do have that in Italy, promoting telehealth to making care there where people live and work, but also normative and regulatory frameworks that have to be put in place at the national, regional, but also local level. We do rely on technical infrastructure. We do need, of course, economic investments, and now we're using funds from Europe to support this transition to telehealth and teleconsultation within the National Health Service, but also in the private sector. We heard from Miguel that also training and education, not only of healthcare professionals, but also of people, is key to make use of these digital tools to overcome physical barriers. We need to quantify through research how effective the impact of such solution in reaching people. So we need solid study designed to quantify the impacts of that solution so that we can truly inform decision-making and policy-making in a constant need of monitoring and evaluation the process to transform physical services into online and teleservices. So with that, I thank you all for your attention. Looking forward to the discussion.
Anna, thank you so much. And I think that links quite perfectly with what Miguel was reporting earlier, because as you have presented, telemedicine, it does actually empower people, patients to access health services. Now, we've come to the end of the second block, but before we go into the discussion, we would like to ask our colleague, Rosa, for some reflections from the patient perspectives. Rosa is from EPHA, the European Public Health Alliance, not to be confused with EUPHA, the European Public Health Association, which is our partner in this webinar. But now, Rosa, please, your reflection on what you heard.
Thank you so much, Matthias, for the invitation to be here today and to share a few reflections. And yes, indeed, EPHA is an NGO that represents a diversity of groups. So that includes patients, but also NGOs that work on disease-specific groups and that represent groups that were mentioned by the speakers before and that are often left outside of these important debates. For instance, homeless people. So my first reflection, I think, goes into that direction. I think we need to make sure that patients and that people, also as it regards, prevention services and health promotion, are part of the solution. And at least in two ways, right? I mean, we heard from the other speakers, we need to better understand the root causes, the different barriers to access to care. And we need to also make sure that people are also co-designing and designing since the beginning the solutions to those barriers. And how can we do that? I think here the other point I wanted to bring is that civil society has a key role to play, because civil society can facilitate really the engagement of a diversity of people and groups and communities that otherwise wouldn't have a very easy way into engaging in the democratic debate that we're talking about. So civil society can do a lot, and it has a lot of specific expertise. I will mention some examples that can help us see how can we go further. What we often lack is the support, and that also it's very important. If we are serious about empowering people, it's also very important that civil society has the support it needs, including financial support, to organize the communities and the people so that they are heard when the telemedicine services are designed since the beginning, or any other services that are addressing these issues. My second reflection is actually about one issue that was mentioned before, and that is often not very visible. And this is one key barrier that often overlaps with other barriers. And it is about the role of discrimination and biases, and this includes racism as a barrier to access to care. And the reason I'm mentioning this is we also work a lot with some populations, some groups such as homeless people, Roma communities, undocumented migrants, and some of these groups face multiple barriers at the same time, and bias and discrimination plays an important role here. What do we need to do, or what can we do here? I think we have to, first of all, like I mentioned, make this invisible problem visible, so study it more, and make sure that the voice of the affected people is heard throughout the process. And we recently at EPHA led a statement that was signed by different organizations across different sectors, calling for stronger action by the EU, by other policymakers to address racism and discrimination in a systematic way. I will also share the link because we have only a few minutes here. And I would like to now go to the third reflection, which also builds upon what the speakers have mentioned. And I think that the one key point from today's discussion is that we have made very good progress in the indicators to measure the root causes. I mean, you all show a lot of data to understand the extent of the issues that we're facing in access. We are progressing, but there is still insufficient tracking. And this is because some of these indicators fail to capture the experience of people that are living. For instance, it was mentioned that people in some statistics at EU level, people living in communal housing or in institutions, so people living in prisons, psychiatric hospitals, or the homeless people or undocumented migrants are usually not included, because these population-based surveys are actually looking at the people in households, basically. So data from citizens and from people is key. And related to that is that good solutions to tackle these and to go to the people, to the most vulnerable groups that are often left outside of these indicators, is coming from civil society and from NGOs that work directly with these groups. Two examples here, for instance, are studies that have been developed by Médecins du Monde and by PICUM and other organizations that have gathered very important data on marginalized groups, including undocumented migrants and homeless people. And these studies can really add a lot to the understanding and to make the invisible part of these issues more clear. A second part or a second good practice that has emerged is also the work done by the OECD on patient-reported indicator surveys. And this is called the OECD Paris, that is being also piloted with different countries to make these indicators standardized and to measure the outcomes from the perspective of people and the experience of people that mostly matter to them. And that includes access to healthcare, waiting times. And an important aspect of this is that it is taking the approach of a holistic experience rather than only going to the quantitative assessment of the condition of patients. So overall, I think I wanted to just finish this reflection by saying that it is very important that we have, and it was mentioned here, granular, standardized, and comparable data, so that we can compare the situation and we really can keep track of progress at all levels, including the most marginalized groups. I think, it's something that we repeat often, is that the health systems are only as strong as the weakest part. Thank you
so much, Rosa. Thank you for this excellent reflections. And I think you have actually reconfirmed our choice to call this webinar, to use the metaphor of the patient's journey. And I heard a lot of things, which echo what the previous speakers were saying. And in principle, you were talking about inclusivity, which was already mentioned by Bernadette. You wanted to have the patients in the center. You give civil society a clear role, actually arguing and supporting patient. You were talking about the role of discrimination and bias. Ewout mentioned it very briefly, but also, of course, Bernadette. And of course, one of the things is the visibility of the people, so that the people are really part of the solution and that we know what the people actually are demanding, what they want, what they need, and how they feel about it. That's great. Thank you so much, Rosa. And we now have still time for a quick round of question and answers. Erica, has the chat box been still busy?
Still very busy, and everybody's sharing resources, which is really lovely. So thank you. Please do continue to do that. So a couple of quick questions. One for Luigi. How can countries work together to share capacity across borders in order to relieve backlogs? Is that something that you've looked into? When it comes to navigating systems and health literacy, this is a question from Miguel. Someone highlighted the bureaucratic barriers that people face around filling in forms and things like this. So what would you do how would you address that as an issue? in supporting people to navigate health systems. And one for Anna, is there a role for the EU and WHO in regulating digital health tools? And a big question for everybody, but probably mainly for Anna and Ewout. It's about the research gaps. What should we be focusing on going forwards? What should be our research priorities? So,
excellent questions. Unfortunately, we need to be a bit brief, so please go ahead. Shall we start with Luigi?
Yeah, well, thanks for the questions. I don't think there is much to gain in cross-border care in the sense that, we discussed this quite a lot, but if you look at the flows across countries, these are fairly limited, and many countries are struggling with the capacity just for themselves. So hypothetically, there are some policy initiatives there, but the substance of this looks very, very limited. Thank you.
Can we ask all the speakers to switch on their cameras? And now, Miguel, yes, please.
Okay, thank you so much. That's a very, very important question. We have been trying, at least in Portugal, and I know about some of the other countries around Europe that are struggling to make easy processes, because everything needs to start from the first person when you enter the door of a health facility. That person has to be informed and has to be trained to help you out within all of the navigation, within all of the system. And I believe it's probably one of the most important challenges, not only the bureaucratic part, but also to get information to everyone that is on board. Thank you.
Thank you, Miguel. Shall we ask Anna?
Sure. So we do know that health is a national mandate. So to answer the question whether the European Union and WHO can do something, my short answer is yes, in terms of priority settings. And in terms of regulation of data sharing, think about the European Health Data Space as a very ambitious example on how can the EU regulate access, care, and share data across borders.
Thank you, Anna. Erika, whom do we ask next?
If we go to Ewout and Anna about research priorities going forwards. Oh, sorry, Anna, Rosa. Sorry, not Rosa.
Yeah, go to Rosa, because I will wrap up in the end and may touch on the subject as well.
Sorry, Erika, can you repeat?
Yes, so what should be our research priorities going forward?
Well, I think, I'm not fixing the research priorities going forward, but I can give you two hints. First of all, the research priorities should also be defined along with the populations that are involved. And that includes the vulnerable populations that we mentioned throughout the webinar. And I think that's the main one, but the second one is that a lot of the ideas are already there. So I think some other people mentioned, right, what is lacking now is the implementation of many of these things that we discussed today. So, of course, more research is needed, and we do know the gaps in data and what is there, but we should also avoid to reinvent the wheel and just put a lot of action into that. Thank you.
Very good. Erika, do we have a question for John and for Bernadette?
No pressure, Erika.
Yes. Yeah, I was going to say, question for John and Bernadette. Okay, so for Bernadette, I think a lot of what we've been talking about in the chat is around systemic issues around racism and things like this. What should health systems be doing around anti-racism in order to enable access? And for John, there's been quite a lot of things around your models, but I saw you answered those quite sensibly in the chat, so I'm not going to follow them up on the screen. So you've got away with that one. But people want to see the papers. Put in the links to the papers. Okay.
Thank you, Erika. You've just opened the Pandora's box, so to speak. But I think that the most important thing is, first of all, to be aware. Racism and discrimination is not at the moment a very conscious issue in the healthcare system, because the healthcare system believes that we're doing good for everybody. So we're not racist, we're not discriminatory, and they have no way of either noting or measuring this. So I think all healthcare providers have to be very conscious and have strategies to address this And healthcare professionals need actually to be taught what to do when they are in such situations. A lot of healthcare professionals don't even know, are not aware. So it's just being aware, being conscious, and then understanding how to deal with it. So I think this is the only thing I would advise very quickly at this stage.
Excellent. Thank you not so much, Bernadette. And now that we have dropped John, do we have something for Juliana?
Otherwise, I was just step in and reflect on what Rosa was mentioning, to involve more patients. And we're just conducting a European project where we ask actually patients to select the most essential dental care benefits for them and to get their input, because the dental care benefit baskets were just they just grew historically as most other benefit baskets in medical care. So I think this is a very good example of how to involve patients and to get their view on what they think is essential.
So really including patients and civil society in system design and what coverage healthcare baskets actually should contain. Thank you so much, Juliana. And now, Eva, I think it's time to wrap up. You started it with your keynote and you need to bring it to an end. You heard all the speakers, you heard all the comments and questions through the chat box. So please, you've got 3 minutes, man.
3 minutes for an incredibly rich discussion is not enough, but I will go very quickly through all also the speakers and the elements that we talked about. So first of all, Bernadette, who talked about covering migrant groups as well, gave very concrete policies: patient navigation, health literacy and translation can be provided. The importance of leadership also really spoke to me. Can we do the same for all these people as we're doing, for example, for the Ukrainians that are currently in Europe? Some services are built up really quickly and they're sometimes really excellent. Juliana talked about dental care, which is, of course, one of the least covered areas, and it makes no sense. It should be better integrated into the health system. We have common risk factors with all kinds of NCDs that need to be better addressed. Yes, we need to increase coverage, and especially also for the adult population. It's not just a personal responsibility after you're grown up, your dental health. It should be a public responsibility. John talked about financial coverage, and he made very clear with his nice simulations that with smart policies, you can actually target the very vulnerable, even in those countries where OOP spending is high, which is never great. But also with targeted policies to the right people, you can prevent catastrophic spending. Miguel, very nice example from Portugal about navigation and supporting people. What I really took from you was, making a system such that you make people make the correct choice from themselves, and also that you, by doing that, empower them, and that you ask them to co-design the policies that apply to them. I think that is a key issue that kept coming back with the other speakers as well. Luigi making good points about the waiting times and backlog, and of course also pointed out the limitations to increase volume and supply, especially with an already overstretched workforce, which doesn't mean that you shouldn't try, but we need to be careful with that. But also really talked about how to better use demand management as a way to eliminate unnecessary or low value care. And also, treating more people in PC and keeping them out of hospitals, for example. And there are huge differences in Europe that suggest that this should be possible. And I talked about geographical barriers and focused in on overcoming them using telehealth. Why not indeed use those best examples, best practices to scale up and provide those pillars as you shown us, to build a strategy to roll this out over the whole of Europe. Then Rosa was making excellent points from a patient perspective. Empowering the people, co-designing is important, involving civil society. And what I really liked was what you said, to make those people more visible that are currently falling between the cracks. And this is also where our research should be. We should have a way to measure that. We need to better measure and how far discrimination and racism plays a role. We need to include those people in those surveys that are currently not included, which also came up a few times. I need to improve, of course, data collection, but we shouldn't wait for, improving just the data. we should already start doing something about those access gaps that we have uncovered together here today and that are well known. But yeah, that's my input, and thank you very much for this.
Ewald, thank you so much for this excellent wrap up, and thank you so much to all our speakers, to our wonderful audience, and a very special thank you to the European Public Health Association for this great collaboration now in the European Public Health Week. And we hope to see you next week. You see, we have a couple of webinars upcoming. The next one is Tuesday, 30 March. How do differences in organizing public health service affect health systems performance? It's part of our health systems performance assessment series. And we hope you tune in. And if not, hopefully see you in Dublin at the EPHA conference. So thank you so much, and bye-bye.